back, and we are going to keep moving right along. And next up, we have Leanne Weisenfeld. Oh my gosh, I was just talking about that. And she is from the Munzer MPS Center, which many of you will get to go see tomorrow. And you may have seen Leanne if you joined our virtual conference in March. She's the best. I just adore her, and we're so happy to have her here with us today. And I will let you get started.
Well, thank you, Kristen. I adore you too, and thank you for having me. So I am Leanne Weisenfeld, and I've been at the Munzer Center for about 18 months or so. But prior to that, I did a lot of work in the autism community, other rare diseases like Angelman syndrome, tuberous sclerosis, a lot of different spaces of different rare disease, and working with different neurocognitive issues and behaviors. So we're going to talk about some of that today. Here's one of our guys who there's some families here who will see their kids up here on our pictures. And I thank everybody for sharing those with me. So we're going to talk about some of the behavioral symptoms that come along with the MPS disorders. We have been talking a lot in our community about how to describe them. So are they challenging behaviors? Are they interfering behaviors? But basically, we're going to be talking about the behaviors that kind of make things a little more difficult for your individual as often as well as yourselves as parents. How those behaviors and everything evolves over time, a little bit about strategies for support and some things that you can do or look into to kind of help with those issues. And then we'll move on to kind of what is my bread and butter, which is the neurocognitive testing. So a lot of your kids have probably, if you're in clinical trials or you go to a clinic space or you need it for school, they get some kind of testing. And there's lots of people out there who do a really, really great job. And there's other times that I'm sure most of you have met with challenges in getting a good neurocognitive workup done. So we're going to talk about that, why it's important, and how the behaviors that we're talking about impact the testing and how that can be a challenge. And then my favorite part, probably that I always make sure to put in all my presentations, is kind of where I come from, which is a strength-based approach. So instead of, we'll get into it, but that's a better way to approach things instead of my child can't, or I can't work with this kid because. So we're going to talk about those today. So first of all, here's those challenging, interfering, whatever we want to call them, behaviors that can kind of come on when you see the disease progressing in your child. So we're talking about hyperactivity, impulsivity, sometimes aggression, irritability, behavioral emotional regulation can be a big challenge. A lot of times anxiety, social withdrawal, kind of whether that's instigated by the individual themselves or it just kind of happens because of the other behaviors that we see. A lot of sleep disruptions. I know you all are familiar with that and how that can then affect other things. And then a lot of mouthing, biting, chewing, which again can interfere in your daily life and can interfere in the testing that we do. So it's important to talk about. Um, so here's what's interesting. We've been talking a lot in some groups that I'm in where we're kind of trying to work on discussing the challenging behaviors and how we can kind of come up with some consensus about these behaviors in the community. But what is the purpose of these behaviors? So I think it's really important to note, and we've been talking about this a lot, that a lot of times, especially maybe other people that you interact with will think, oh, this kid is being bad, or they're acting out, or they're mad, or they're angry. And that's not always the case. It's actually probably not usually the case. What is usually the case is they're sensory seeking. Your child is trying to communicate. It might be a social interaction attempt, but that's the only way they know how to express themselves because communication is becoming compromised and different things are happening. It can just be a thing of hyperactivity. The body is not as easily controlled, so they might be moving their body in different ways, lashing out. So we are really trying to make sure people understand that most of these behaviors are purposeful and not sometimes in the way that it can be easy to take it. Like, oh no, they're hitting or they're biting or they're angry. But it comes from a place that hopefully we can try to address these underlying issues so that the behaviors can go down a bit. So on that, what is the cause of them? So again, it's not just acting out, right? there's a lot of things that come along with these disorders, like hearing deficits. Again, can't hear, you can't understand, those things need to be addressed. The neurodegenerative cognitive decline can be a big part of what happens when it then affects behaviors. Something else we're going to talk about a little more is making sure to address pain. Because a lot of times, if your child can't communicate, you don't know how they're feeling. They could be in pain. There's different reasons for this, which we'll go into more. The environmental triggers or things in their surrounding that are upsetting to them that maybe they can't communicate, that would be nice to know what it is. So then we can try to change the environment and therefore change the behavior. A lot of times I have anxiety as well. I'm feeling it right now. The anxiety alone can kind of make you feel reactive and feel in a way that you don't know how to do things with your body or how to act. We also have to always make sure to be thinking about seizures or seizure-like activity, and the things that precede that and the things that come after that can make your child feel a certain way that maybe doesn't feel comfortable. And as we know, there comes respiratory problems, which can lead to sleep apnea. And I am definitely one to know that if I don't get my sleep, my behavior might change. So that happens for everybody, including our kids. So these things, all these things can lead to behavioral problems, sleeping problems that then we want to find a way to address. So this is just a little bit about the evolution over time. So this is sort of, these are all kids with Hunter syndrome, and these are the natural history of some of these different disorders and how the cognitive trajectory goes like this, right? And a lot of our behavior trajectory often mirrors this. So when the cognitive decline starts, the behaviors start to escalate. And again, some of your kids are in clinical trials, some of your kids are getting great treatment, and maybe they won't face this as much because the cognitive part might be getting taken care of. Um, so what can we do though? So what are our strategies for support? What can we do when we are faced with these behaviors, these challenges? Um, I mentioned this on the earlier slide. It's really important to diagnose and manage these physical factors, because often the first thing you need to do if you see behaviors escalating is say, is there something concrete and physical that we can look into and do something with? So you need to find a well-versed medical professional. I'm obviously partial to Dr. Munzer, and he always talks about this, right? So there's musculoskeletal issues, there's gastrointestinal issues, there can be intracranial pressure and headaches, the remnants of seizure activity, right? So if you can get those things under control, have some pain management, have some medications that help with your stomach issues, then maybe you don't feel so crabby and feel the need to lash out at your parent when they're just trying to give you a bath or something. So I would say that's the first thing we're telling people, is to make sure you know if there's some kind of pain going on. Once you can hopefully try to narrow that down with imaging or with different, swallow studies, whatever you need to do, then you can move on to the other things. Environmental changes. And again, I feel like this goes with all kids and most adults. Routine and structure feels really good. I was just talking to a family who their child knows when bedtime is and what he likes to do before bedtime. And maybe that makes them sad or crabby if they don't get that time or their routine. So focusing on things in your home, like routine and structure, so they feel safe, right? I feel safe and comfortable when I know what's happening next. So making sure you communicate that routine and what's happening next to your child, remembering that they can probably understand more than you think they can, or more than other people think they can, I should say. Um, Also, address the oral motor issues. A lot of our kids like to put things in their mouth, and that can be interfering when testing. It can be interfering when hanging out at the park. A lot of times you can get the oral motor sensory cues, and then that sensory thing that is making them frustrated or seeking can be taken care of, and they can focus on other things. In my testing, oftentimes I'll say, okay, we're done with expressive language stuff. Your kid keeps putting these toys in their mouth. Do you have a safe chew that they like to use? And then the blocks and all the other things we're playing with don't go in the mouth. Um, Addressing safety issues can, again, make everyone feel safer. So addressing things about getting up out of bed at night, right? So sleep beds or things like that. Addressing safety issues in the home so you're not on alert, they're not eloping. People have lots of gates and lots of locks and all the things, and that can make everybody in the home feel safer and potentially have less issues. And then, like I said, the sleep bed. We've had a lot of families who have recently just gotten prescribed a sleep bed, and they have said it changed everything for their child and themselves. They don't have to sleep with their kid to make sure they don't get up. They can sleep by themselves. And a lot of kids feel really, really safe in those environments, and they like the feeling of being, in a controlled environment. Something else that's very important that is, kind of hard to do sometimes when you're in the middle of everything, but try to work with organizations on advocacy. This can be working with a big organization. This can just be advocating for your child at the school, at their preschool, making sure you tell about what needs they have and how they can help you address those. Um, the other thing is behavioral interventions. So there's things you can do like communicating clearly, positive reinforcement, just all the things that we know as parents are good to do. Another thing is, there's not a lot of clear data on what specific behavioral interventions work with kids with MPS. That's probably because just like anybody else, they're individuals, right? So what works for one kid might not work for another. However, there is some data that it indicates that ABA, which is often used for kids with autism, can be really beneficial for kids with MPS. It helps with learning, it helps with structure, and we'll get into a little bit more that oftentimes the problem is you need different diagnoses rather than just MPS in order to qualify for ABA. And that's a whole nother conversation. We'll touch on it a little bit, but one of the things I'm pretty passionate about, and we're trying to, advocate for kids to be able to get different services without meeting what has typically been set as the criteria to get those. Another thing that is very important can be medication. It might be really helpful. Unfortunately, it's oftentimes in this community trial and error, right? You try something, actually, that had the opposite effect of what we wanted. We're going to have to try something else. So that is still kind of an evolving field. And again, everybody's an individual, so you don't know what will help. Sometimes it can be anti-anxiety drugs. It can be ADHD medications. There's different things to try, but you need to find someone who knows your child well and who knows MPS in order to really I know that's very hard, but it's beneficial if someone can really keep a close eye on when you get medication changes. And then support for family, and I think that's why we're all here today. It's really important to for you to have access to services, be part of parent support groups, try to get respite care through your state funding. I know that can be really helpful to find a good respite care provider. And then social support just from the community and family and friends. And I know a lot of you have very active Facebook pages and have community members that come to the walks with you and everything. And that is really important. It's important for anybody, but especially kids who have a child with rare disease. So now we're going to talk a little bit about testing in MPS. So the why and kind of the where you might see this. So what I do a lot at the Munzer MPS Center is the standardized assessments that are a part of clinical trials. I also see kids just for clinic visits to do assessments and give the parents feedback on, according to the measures that we use, how their child is functioning, which is important to say. So they can help monitor the growth, the development, and then we can also keep an eye on that possible decline, depending on where you are in your journey, that can come along with having a child with MPS. Um, it can help you with access to services. So a lot of times in order to get speech therapy, they'll say, well, we need to evaluate your child and make sure they fall low enough to get access to speech therapy, right? So some of these evaluations that we do, they'll give information about receptive and expressive language that can be helpful for you to get services. Um, it's actually also to be eligible and to be a part of a lot of clinical trials, which is a lot of the work that I do. They have to have baseline data, and then we have to track them over time, right? To see how the tests are going, how the child is developing. So that's really important. Um, And then kind of like I mentioned with the ABA, some assessments results can be used to identify what we call comorbid diagnoses. Does your child also have an autism diagnosis? When that can be written, then you can have ABA. Again, I wish that wasn't the way it had to be, but it usually is. So sometimes you can come in and you can get an evaluation with somebody and learn, yeah, there's an ADHD diagnosis, and I'm going to tell the school that, and that helps with the services I get at school, or I have an autism diagnosis. So where is this going to happen? You could do this in a clinic setting as a part of a complete workup. Again, we have that at the Munzer Center. People come in, they see Dr. Munzer and my other colleagues. They talk about clinical trial space. They talk about what your future might look like. They can see me and get a workup through me about all the different testings. And then we can send you a report and you can keep an eye on how things are going. It can be part of a trial. You might see these tests when you are seeking a diagnosis. For the younger families, a lot of times the journey was something else is going on, right? There's testing, something else is going on. What is it? There's testing, something before you get to MPS. So sometimes you've done a lot of these things before you get to the MPS space. So you might have been through these things before. The other thing is for school placement. So sometimes schools are going to want some kind of evaluation to know where is the best space for your child to be in a classroom setting. Do they need a one-on-one? What is the feedback from a clinician like me about what would be best for them? So what types of tests might you encounter? So there's developmental tests, which are usually done with kids of younger ages or a little bit lower abilities, and they're pretty play-based. There's regular old IQ tests, which I do with some of our kids as well, that feel more like a test. There's achievement tests, which kind of say how you're functioning if you were in a grade in school. What does that look like, your achievement? And then there's a diagnostic test, like we talked about, for autism, ADHD. And the last thing that I'll go through is about adaptive behavior. I know all the families in this room that I know have done the adaptive behavior interview with me, sometimes more than we all want to say that we've done it together a lot of times, but that is to find out how your kid is functioning in their environment and in at home. So not just how they do when they're in a room with me. So, quick overview of the developmental testing that you might see. It's mostly what we do nowadays is the Bailey. It's the gold standard of neurodevelopmental assessments. It's used in most research, clinical research, academic research uses the Bailey. Thankfully, you see the kit there. It's pretty fun for at least a time for some of these kids. It feels like play to them. And it can be pretty quick if you need it to be, and it can feel pretty play-based and fun. Clinicians really have to be adequately trained to do this, especially with the rare disease population, which can be a little more challenging. It's very different to do one of these assessments with a child with a lot of, as we talked about, interfering behaviors versus just a typically developing kid. So I would caution you that if you get somebody who doesn't really know as much and has having a hard time working with your child, try to seek out a different place or a different person who kind of understands the needs and the need for flexibility. So this Bailey is telling us things about cognitively, language, and then motor. So we're going to go into each of these things. So your cognitive subdomain is going to be things about interest in new things, manipulating toys. This picture here is, hey, I'm going to push this duck to the ground. Do you understand to look where it goes? A little bit kind of object permanence. Where did it go? Finding hidden objects, doing puzzles, matching things. So everything you can go until it gets a little bit harder for the child. And then we have receptive language. So here's me on the floor with a child with Sanfilippo syndrome, and we're just looking at books together, right? So sometimes it might be hard to tell what she understands and what she doesn't in her decline with Sanfilippo. But hey, listening and sitting and listening to a book and attending to it is receptive language, and it is listening and it is learning and it is paying attention. You'll also see she has one of our little sensory chews in her mouth because she loves to put things in her mouth, including that book. I have multiple copies of these because they all get chewed up, and we use lots of Clorox wipes at my job. So it can be that, and then as you move a little bit higher, it can be, hey, show me the, where is the, pointing to things in books. I know some of you parents here have seen me do this a million times. And even interactive games. So this child in particular too, she loves a good game of patty cake, loves it, and gets very excited. And that is receptive language and being engaged with others. And then we have the expressive subdomain, which of course means babbling and requesting and just plain old talking. But it's important to point out this is one of our little guys with Hunter syndrome. And he's at the airport getting ready to come for one of our clinical trial visits that he flew here for all the time. And he's pointing, right? So he's using his expressive language. He wasn't able at this point to use words, but he was definitely showing mom and dad everything he wanted to show them. And that's important when you're working with a child to just notice these things. Some of these things I do aren't administered directly per se as a lot of observation. I'm like, oh, look at them pointing and showing me things. Look at them engaging. So that's really important. And then we have one of my favorite little guys here. And this is the fine motor subdomain, right? So this can be, normally I use a different slide here where there's somebody grabbing these little red blocks, which any of you who have done these tests have seen me use those little red blocks a million times. But this picture is too cute and I had to use him. So it's block play, using crayons, picking up small items, Cheerios, 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 right? Pincer grasp. So it's all these kind of things that we're seeing. As they get older, it's writing things, it's using scissors, it's all of those kind of things. But these are the precursors to all of that. There's another one of our guys, and he's showing us how he goes up and down the steps. So this is our gross motor. So we're talking jumping, running, it can start at crawling, it can start at rolling over. Is your child rolling over at an appropriate age? So we look at all those kind of things. So that is a quick synopsis of the Bailey. And then you have other, I'm not going to go in as much, the cognitive and IQ tests. As you see, they're a little more boring. They're a little more, it takes a little more to keep kids on track doing these. It's less play-based, more structured. It can more challenging to administer because it just isn't as fun. I try to make it as fun I can be while being standardized as well. It's a fine line. And not all of our patients at the age that this test starts will necessarily be able to complete this assessment. However, a lot of times they age into it, they learn new skills, or we can keep assessing them using the other measures, the developmental tests I was talking about. And then there's these achievement tests, which sometimes the schools will want these. So this gives more, again, it's really structured. It includes more things like math, spelling, writing, reading. So it's not the IQ like abstract things. It's actually basically the things you learn in school. So they want to see where your placement would be in school. They're going to ask for something like this achievement test. And then, of course, we have the screening for autism. Like I brought up earlier, you might have seen this during your diagnostic journey. You might have been saying something's going on with my kid. I know there's something going on. And people say, oh, I think it's just autism. I think, let's do some testing for autism. So some of you might see this before you even get an MPS diagnosis. Some of you might see this come later as some of these autistic like symptoms and behaviors start to come out as your child ages and progresses in their journey. Um, so school placement, a lot of times too, they need this for what classroom you're going to be in. Do you need to be in an autism classroom? Do you need to be self-contained? Do you not? Needing a diagnosis to receive services, like we talked about. So how is the autism screening done? So we do questionnaires, we do interviews, and the biggest thing that's kind of the gold standard is called the ADOS. So again, talk about a fun kit here. This is even more fun than the first one. This is the ADOS. There are about a bajillion toys, a bajillion prompts and things to do and pretend play. So it's standardized, but it's very semi-structured. So the kid definitely feels like you're just playing with them. You're bringing out toys, you're seeing how they play with them, you're giving them some prompts, seeing how they react. Um, as they get older, there's some more like storytelling and discussion, and you ask questions to see if they have insight or what their verbal skills are like. Um, and this is the gold standard. And again, if you want to or need an autism diagnosis, this is probably what you should ask for when you go to see a clinician. And again, if they're not if they don't do the ADOS often or don't do it with kind of challenging individuals, I would try to seek out somebody that does. Um, So the Vineland that, like I said, I think a lot of you have maybe done this with me many, many times. And I've done this for the multiple iterations of the Vineland over the last 20 some years. It's a great tool because a lot of times these clinical trials, for example, are looking for changes in scores on developmental or cognitive testing, right? Some of our kids just don't test well, or they don't test well because they just traveled here on a weird schedule, right? And they're not sleeping in their own bed because they had to come to Chapel Hill. This is where you get to tell me how your child is doing at home and maybe how that has changed, right? So you might say, the first time I talk to you, they're not dressing themselves, right? By the 15th time we do the Vineland, my kid is pulling up their shorts by themselves after they go potty. I had a family know that one of the things I have to ask about in this every time is your child jumping with both feet off the floor? Because we talk about gross motor. And again, in my clinic, sometimes I can model it and I can show them they don't feel like jumping with both feet off the ground, so they might not. But the family can tell me, "Oh my gosh, they learned." I had a family recently text me on a Friday out of the blue and say, "Guess what? She just jumped with both feet off the ground." And they were so thrilled, and I was so thrilled, and I said, "I can't wait to do the Vineland again, and you get a couple of extra points." But it's those things that they're doing at home that they're not gonna show us. It's about social interactions, right? So you're gonna ask, I guess I should move to that. You are gonna ask about socialization, interpersonal relationships. Maybe at daycare, they started playing more interactive play with other kids instead of just parallel play. I might see that a little bit when I'm working with them because they take the baby doll and hand it to me to burp it or something. But are they doing that with their peers? Are they approaching kids on the playground instead of keeping to themselves? Um, and like I said, you're going to learn about daily living skills. I like to talk about how important it is because the daily living skills in particular, I feel like is something that, you know, some families know or think that I might not ever be able to get my kid to write his name or to read, War and Peace. Okay, sure. But how do they function? How do they function at home? How are they able to take care of themselves and feel valued in the home and help you with things? You take them into the kitchen, you start letting them help you make dinner. And years ago, when I worked in the Fragile X community, which was the first place that I kind of got exposed to the more rare diseases, I had a family that we went to their home and we visited them in the home to do the assessments, which was awesome when I was young and no kids and could travel everywhere. It was super fun. But the mom really wanted to show me that, yeah, you just did that testing and he didn't stack blocks for you. And he really doesn't like to write his name. And don't try hand over hand with him because he hates that, which a lot of the kids do. But she was so proud to show me that when he got home, he went and he put a bagel in the toaster and he got the peanut butter and he used a knife and he was learning to spread his own peanut butter and make a snack. And that is not something I could test on my Bailey or whatever I was using at the time, but that is something that mattered to them. So families change their priorities as your child's ability changes, right? If you need to say, I just want them to be able to go in the kitchen because they really love it and I want them to be able to make a snack and be independent. If that's what you wanna focus on, then you can focus on that. And then you get to tell me on the Vineland. So it can be a really rewarding experience, to be able to tell the things that your child is doing in their own environment, loving bath time, helping with bedtime routines. So that's why I like the Vineland so much, although I'm sure parents get a little tired of doing it all the time. Um, so when we talk about the behaviors and the impact of behaviors on testing, and I'm talking about the testing that I'm doing directly with your child, there's lots of things here in this publication, the considerations for testing, right? The hyperactivity, the motor deficits, corneal clouding, right? Hearing impairments, slow processing, inattention. And then it has all these things that you can do, your recommendations that you can do as a clinician and you can do as a parent, even when you're just with your child to kind of mitigate some of those issues. So basically, what do I do? And what do most clinicians that work in this space know they have to do in order to gather accurate data for you as the parent, but also for the clinical trial space, right? So what we do, my thing, like I said, I love to talk about is the strengths-based perspective. Remember what your child can do. Get really excited for them when they do it, and that kind of encourages more, right? Make sure the clinician that's working with your child is prepared. They know the instrument, they know how to work with kids with challenging behaviors or different abilities. I like to also make sure I give guidance to parents and caregivers. Yeah, you can be a part of this, or hey, why don't you back off and let me see how they do it a little bit? And being flexible. So, my husband would probably not agree that I'm flexible, but maybe I use it all up in my space at work because I think I'm very flexible. I had a kid in for clinic and she just didn't like the room where we were and she was pacing and trying to get out and I knew I wasn't getting everything out of her, made sure the hallway was safe and that we could kind of walk around, and we walked around and I took some of my things with me, and she ended up, for those of you who've been to the Munzer Center, you'll see it tomorrow if you haven't. Um, she leaned over on one of the hospital beds that we have there for infusions, and I plopped the puzzle in front of her and she wanted to do this with the puzzle, gave her the puzzle pieces, and there she was, and she filled in the puzzle. And if I had stayed in that room and just said, "Sit in your seat, do my puzzle," and it wasn't working. And I was like, I feel like there's more here. So flexibility. I've learned to wear tennis shoes and comfortable clothes on the days that I work with kids because you might be running around. And again, find a clinician who's going to do those things for you, for your child. Um, the strength. I love this picture. This is one of our teenagers with MPS, and this is the perfect picture for strength. But I like to get feedback from families about what they think is a strength of their kid. What do they love about their kid? And you see determined, imaginative, loves to sing and perform, affectionate, infectious laugh, resilient, right? There's a lot of things that you know about your kid that you want other people to know. And I want to know that too. So it's important to use these things that we see in these kids while we're working with them, whether that be just a clinician like me or Dr. Munzer does this, right? Or all the other professionals that you see. So I think it's really important to present the things that your child has done back to you in a strength-based perspective as well. Look what they're able to do. They're really progressing here. They're working very hard. Um, so I won't get in this too much because y'all aren't the clinicians, but again, somebody that is a clinician should be able to remember that parents are the expert on their child. I might be the expert on the test, but you know your child, so you can say to me, "Hey, they don't like big claps and waves when they do something exciting. They like it low key. Hey, give me that feedback." Incorporate strengths, maintain the integrity of the test. Something else that's really important is and this is something you work with the parents with, is when you're trying to schedule something for your child, you know what time of day your child is at their best and when they might work the best. So being flexible with scheduling, if at all possible, so that we're getting the best out of your kid. Normally for kids, most of them, it's first thing in the morning. I say the earlier the better for me. Are they up at 6? You don't have to wait till 9 to come see me, right? My son would be sleepy by 9 when he when he was, younger. Go ahead and come in, have a comfortable testing space, expect the unexpected, be flexible, take breaks, and have snacks. And this is where it comes back to whoever's bringing the child to their assessment, bring snacks, bring the things they like that are going to comfort them, or that you can use for like, hey, if you do this first, then we get our snack. Um, this is another one of my favorite little guys. And this is just like get on their level, right? Join in their world. Lots of positive reinforcement. And like I talked about with snacks or with, hey, when we're done, you get to pick one show on your iPad, but you have to finish. And sometimes you use less words than that, or you use how you use to communicate that to your child. But reward system, we all have to do it with all of our kids. Um, and then again, as a caregiver, how you navigate the session. You can ask the clinician if they're open to feedback. This is where you can say, "Hey, can I tell you?" And I might say, "I totally get that. I can't present it that way. That invalidates the measure. But then after I see how they do it, I'll do it your way and let them be successful, right? Let them feel like they accomplished something. But also be mindful of interfering too much and spoiling it. I've had a few instances in my years where you have to say, I understand, but I really have to see what your child can do. I've been on the other end of that. Of course, being in the space I'm in, my poor children have been in multiple little research studies. And when they don't do what you know they can do, it can be very frustrating as a parent. And you want to say, they can do that. I'm going to make them do that. But it's important to kind of do the balance there. Um, so talking about the balance, I'm hoping I can make this work. So this is a good illustration of what oh, I don't think the other one's there. I hope it's there. Let me check. Yeah, it is. Okay. So as long as I can make this go, where's my mouse? Hang on. Oh, I will say technology is not my thing, as you can tell. Give me your kid today and I'll take care of them all day long, but don't ask me to figure out where my mouse is. Let me see if it'll do it. So this is an example that is part of a training video for doing that Bailey that I was talking about. And this is some gross motor thing where you're trying to get the kid to stand on one leg. I often say, stand like a flamingo, look at me, do this. So, oh, it's not working that way. No, can you help me figure out how to make this go? Every time I click, it just goes to the next slide. So it's probably just me. But this is my favorite. There it goes. Okay, if you stay so you can help me with the next one. This is the training example. Sure. Yeah, no problem. I'll bounce on my right foot for you. No problem, lady. Thanks. Yeah, got it. I'll do it. But is that realistic? So here's a child with San Filippo. Love her to pieces. We have a lot of fun. She has a lot of energy. She loves pretend play. We work that into the assessment. But and the reason I videoed this was I said, if you do this for me, I will let you watch it on video. She loved to look at my pictures and look at my phone. I will video you and then I will show you yourself if you will just do this. Her mom was there trying to help, etc. So this is what it often actually looks like. See, it's hard to find.
On that screen.
Oh. Yeah, so there you go. Day in the life right here. I'm good. Thank you so much for the technology assist. But as you see, look, we were cutting. There's stuff everywhere. We had our pretend play things. We had our squishies. You know, I try to clean up stuff so it doesn't distract because ADHD, you know, all the things. But yeah, you know, this is the reality. And so just also so you all know, we're used to this. I'm used to this. Don't, oh, I'm so sorry there. Oh, yeah, I'm good. I got it, you know? And guess what? She didn't ever stand like a flamingo for me. She just wouldn't do it. She can stand on one foot. She can hop on one foot. We tried, you know, pretend we're playing hopscotch. Not in the mood. Really loves to sing and dance and be dramatic. I love her, love working with her, but if it's a question on the Vineland, can your child hop on one foot? Mom can say, oh yes, you know, you and I both know she can hop on one foot. And I said, okay, that's what I thought. Um, okay. So to wrap up, there's some of my other favorite people in the room. And so, yeah, so each of our experiences are going to influence how we work with families, right? So I'm going to remember to know about the behaviors that I might see. I'm going to be prepared. Um, but it doesn't mean that I can't learn something every day, like learning that standing like a flamingo and videoing doesn't work, right? And so we got to try something else. So it's just really important to find a place and some people that really seem to understand you and your journey and are understanding of the behaviors and the things that you might face in your daily life. So there's just some references and another great little pic of another favorite friend of mine. And yeah, so that's it. So thank you for having me today. And if anyone has any questions, I'm happy to answer questions, or you can find me. I'll be here for a little bit.
What other diagnosis besides autism will trigger?
For ABA, it's normally just autism. And that's something we're talking about a lot, and we're trying to make changes in that space. Unfortunately, a lot of times you have to seek out that autism diagnosis. And if your child has has all those attributes and they can actually get that diagnosis, it makes sense. Sometimes though, it's hard to get that. It's hard to get in somewhere and get that testing done. Or sometimes they don't quite meet those criteria, but they'd still benefit from ABA. That is a big challenge, I'll be honest. Typically for actual discrete ABA, that is the experience that I've had with getting ABA for people. It's specifically autism diagnosis. But again, we're trying to kind of open that up into other spaces where there's so many kids that would benefit from it. Even if they don't quite have autism, the concepts are there and that would help, or just some other kind of behavioral interventions, right? But that's the most discrete, well-known one that is the easiest to find in your community, usually. Yeah. Anybody else? Okay, thanks, y'all.
All right, this is the first year we've ever run ahead of schedule. I almost don't know what to do not running late. So that's amazing. So what we will do is we'll go ahead and just take our break a little bit early. You have 15 minutes. And as long as our next speakers are good to start a little early, okay, then we're gonna get started. We'll start back here at 9:50. So there's still food out there. Have at it. If you need to go check on the kids, anything, go ahead and we'll be back in about 15 minutes.
Yeah.
Oh, yeah.